Good evening, all.
Yes.
I welcome all the delegates of Maha-IP. Also, I welcome our President, Dr. Ram Gopal Chezara, sir, and our Secretary, Dr. Amol Pawar, sir. Today, we are here for Learn with Legends. Learn with Legends, Maha-IP has started this series as our legends in each field will share their experience and knowledge with us. This program is scheduled on every third Thursday of every month. This is the 5th episode of this series. Today we have pediatric interventional cardiologist Dr. Srinivas sir. For today's session, Suno Dil Ki Puka, that is lessons from the little hearts. I will invite our president, Dr. Ram Gopal Chezara sir, to have few words with us.
Thank you, Pushkar. Good evening, friends. Welcome to the another episode of Learning from the Legends. Now, as the title itself suggests, that we are inviting legends from the respective field. So, as you know, the today's topic is the cardiology, and we have invited our legend from Thane Jupiter Hospital, Dr. Srinivas. He is an interventional cardiologist also. So I will not take much time, and we want to listen his Dil Ki Pukar. So over to Pushkar, you, and we yes, Pushkar, you can invite Amol and then we can start.
Now I request our secretary, Dr. Amol Pawar sir, to have few words with us.
Thank you, Pushkar. Already Ram Gopal sir told about Dr. Srinivas sir. He is known all across Maharashtra and bigger part of India also for his skills in pediatric cardiology. This learning with legend, this is 5th episode, and we know that we have been taught by our teachers, and so this series should continue, and the legends are there to help us at every step in our practice also. So everyone has teachers, legends in their minds, and this year we have started this series to learn from these legends about various tricks in our office practice. So this time, this learning with legends, this is coordinated by Dr. Jayan Shah sir, our Maha-IP executive board member from Nandurbar, and Dr. Pushkar also. So I, from team Maha-IP, I welcome again all delegates, all PG students, then all executive board members, past president Dr. of National IIP, Dr. Jayant Upadhyay sir, and our scientific convener Bhavesh Mithia sir also. So without wasting time, I straight away ask Pushkar to go forward in this webinar. Pushkar.
Ma'am, please share sir's CV. Yes. Dr. Srinivas sir, I request Dr. Srinivas sir. He is the pediatric interventional cardiologist at Jupiter Hospital, Thane, and visiting consultant at Sion Hospital, Mumbai. He has done more than 3,000 catheter interventions in the leading center for neonatal and advanced pediatric and structural cardiac intervention. He is also advanced imaging, including fetal echo, cardiac CT, and MRI. He is active in academics, teaching, and clinical cardiology. His major achievements as important awards in academic, most challenging case at Structural Interventional Award at ACT Chennai, India. Best Intervention Case Award at Asia Pacific Cardiac Interventional Symposium, Seoul. Also, he has A.V. Gandhi Award for Excellence in Cardiology, gold medal with citation. When he is free, he is also passionate about travel, wildlife, trekking, photography, and marathons. So I welcome Dr. Srinivas sir to start with his presentation and also request all the delegates, if have any questions, please write it in the chat box. Over to sir.
Sir, kindly unmute yourself.
Okay, yeah. So I have
thank you.
unmuted.
Yes, sir. Yes, sir.
Okay, just a minute. Yeah, I think the first slide is on. Good evening, friends, and thank you very much for this opportunity. Today we are going to discuss about a few clinical case scenarios and try to get as many stories as possible from what we have learned over so many years in pediatric cardiology practice. I have mostly tried to collect clinically relevant cases for the pediatricians so that it will be useful for all of you. And also during the course of the presentation, we would try to burst some of the myths that we commonly have about pediatric cardiology. So let us see how we go about. So as I said, it's all case presentation after case presentation. If you want to ask some questions, you can please type those, and Pushkar will stop my presentation in between and sort out the questions from case to case. Okay, so that will be the scheme of presentation. So if it is an interactive presentation, everybody would learn. So it will be fun to learn. Like a masala movie, you might have a few songs in between. You might have a lot of thrilling sequences in between. Okay, so the entire presentation is to keep the light mood. So let's start with this. Again, once again, thank you, Mahayapi, for this wonderful initiative and providing this opportunity to me to present in this big forum. So now when Bhavesh asked me to do this, the first question what I asked Bhavesh was, so the title says learn from legends. So is it okay that I present as a legend? So that was the biggest question I have, because we all still consider ourselves as a student in this specialty. So we are continuously learning. So just reviewing my story. So this is my alumni. So it's a BM Patil Medical College, Bijapur, from where I graduated. So there is a story for each and every picture that I'm posting. So mostly we are going to concentrate on the clinical material today. So I have passed out from here. I'm a 1993 batch Buildy alumni. So as with the God's grace and divine blessings, I got into Satyasai Hospital as a cardiology resident doctor even before I did my post graduation. So in this hospital, I worked for 3 years, 3 precious years, learned a lot. So this is Dr. P.K. Dash, who is with me in the picture, one of the greatest teacher of cardiology in the country. So then I got into Amrita. So this is when I did my DNB Pediatrics. Again, a great organization, beautiful institution, a lot of good teachers. So who actually laid my foundations for pediatrics, always indebted to my teachers. So I happened to meet my mentor, my guru, Dr. Krishna Kumar sir. So who has taught me the basics of pediatric cardiology and always continues to be an inspiration for me. So all this while has taken about 15 years time to find the purpose of my life. Once I was into cardiology, then my life was sorted out, I think. So I knew what I wanted to do always. So this was a short stint in Australia when I was a pediatric cardiology fellow. And I was also awarded a honorary EP fellowship in this organization. So since then, I am firmly footed at Jupiter Hospital as a consultant pediatric cardiologist. I'm very glad to say that we have been able to establish a state-of-the-art cardiac center here. We have done more than 3,000 structural interventions, more than 6,000 total heart disease cases that we have done, either surgery or interventions. We have an excellent, vibrant PICU setup. All of you know Parmanand very well. We have an excellent ICU setup with us. So we have a robust fetal echo program, which we started last year, and we are building on this. So we have a very active structural intervention program where we start treating from neonate to old age adults, including TAVIs and mitra clips and things like that, very advanced level. So of course, we are proud to have a few academics and publications as well. So with this, so let us tell you another small snippet. So these slides are borrowed from Dr. K.M. Cherian, again, one of the legends of pediatric cardiology in India. So this slide, I got this slide from him when we actually launched Jupiter Hospital Pediatric Cardiology Department. Yeah. So this has a very significant date to this publication. As you said, it's a paper. As you see, it's a paper clipping. Okay, so the date here says 14 March 1975. So this date happens to be my birthday, official birthday. Okay, so that means I was destined to be born on a day when the first pediatric heart surgery started in India. So that is how the luck favors and this is how the blessings happen. Okay, so these are all the paper clippings from 1975. So these are the Dians of Pediatric Cardiology, Professor Raj Tandon from All India. Sir is no more. This is Professor K.M. Cherian from Triple M Madras. So these two are the pioneers of pediatric cardiology in India. So these are all my teachers. They're all second generation pediatric cardiologists who are direct teachers to me. So many of you might know Dr. Krishna Kumar sir. Many of you might know Dr. Shiva Prakash and Suresh Rao sir. Both of them are practicing in Mumbai right now. So in very good organizations. So this is a team of teachers for me. This is all the team from Amrita Institute of Medical Sciences. All of them are Amrita alumni. Right. So what is the role of a pediatric cardiologist? Is it only interventions? So the intervention part in a pediatric cardiac program is only limited to about 20% of my time. Whereas most of my time is utilized in doing imaging, doing ICU work, doing academics, doing social work and community pediatric cardiology. So when we perform this 80% of work well, then we can perform this 20% of the work well. So I'm going to take you through various case scenarios regarding this. So before that, let us answer these very simple questions. So how common is heart disease in a neonate? So as per all the literature world over, it is about 10 per 1,000 children. How many of them need surgery? About 20 to 20% of them need surgery at some point of time in their life. How successful are surgery? For a routine lesions, which would require a single operation, the success rate in present era, including at Jupiter Hospital, is more than 95%. For simple lesions like ASD, VSD, PDAs, TGAs, TAPVCs and all, the success rates are more than 99%. That means hardly there ever is a loss of life when these patients undergo a successful heart surgery. So is cure for CHD possible? Yes, it is possible. Most of the times, 80% of the times, we would do a single curative procedure for all these babies. Small percentage of patients, about 20%, they would require multiple staged palliative procedures. So otherwise, it's a curative procedure. There are unfortunate patients where we can offer nothing. That means the disease is so complex or the physiology is so bad that we may not be able to offer any surgery for those patients. Luckily, they are very, very tiny percentage. So the another tiny percentage is those who are inoperable. These are the patients who present to us late, where ICL mineralizations has happened. Luckily, this bubble is very small right now because excellent primary healthcare is possible in most parts of the country, and late referrals are very rare nowadays. So we get referrals at appropriate time most of the times. Okay. These are the very common questions for pediatricians. The children who come to us for echocardiography, we suggest them a procedure. They would go back to their pediatricians and ask all these questions. Okay, so what happens to my child? Can he attend schools? Yes. Can he play sports? Yes. Can he do cycling, running, or whatever activity, physical activity? Yes, they can do normal. Okay, so what happens if the child develops fever after heart surgery? Yes, nothing happens. Treat them like a normal child. Does the child has any dietary restrictions? No, not at all. A child with heart disease has no dietary restrictions. Child can have a normal diet and a lifestyle. Can the child have vaccinations before or after surgery? Before surgery, yes. So they should get all the timely vaccination, including the optional vaccines, especially flu vaccines during the seasonal flu. After the surgery, after 2 months, they can resume their vaccinations. This is after open heart surgery. Most of the conditions do permit them to do air travel without a problem. So general fitness levels are excellent. If the child happens to be a girl, she can grow up to become a completely functional woman, can have marriage and pregnancy also. So these are the common questions that every patient asks us and also the pediatricians. That's why I thought I'll just include this in the counseling session as well. Okay, so as I said, curative surgery means the child will have a normal life. Palliative means they have about 50% physical fitness, 80% complication free life, 80% free from redo surgeries, and life expectancy is about 45 to 50%. As I said, this is the minority of patients. So how do they undergo surgery? There are two types of surgeries. Okay, so one is a routine open heart surgery. About 80% of the patients who have heart disease will require an open heart surgery. So there are 20% of patients who do not need an open heart operation. So they would undergo something called transcatheter procedure. What is transcatheter procedure or cardiac cath procedure? So this is similar to angiography. So here, if you see, this is an illustration where we are trying to obtain puncture in a child via a vein in the leg. Once we have this small needle inserted to it, so we have a pathway to enter the baby's heart. So this is how you enter the baby's heart. Once in the heart, we can actually fix the holes or stenos valves. So this is an illustration where I'm actually trying to show you how an ASD is closed. So this is the atrial septal defect. So we put these catheters and the sheets, and then we implant the devices. Okay, this is one of the discs in the left atrium. The other disc is in the right atrium. So this is the procedure where how an ASD device closure is done. Okay, so in real life, how is it done? So I'll just show you in the next slide. So this is an echocardiography patient with a large ASD. Okay, so this is the ASD. This red flow is a large atrial septal defect. This is the ASD in this child. So this is after the device closure. You see this device has been implanted here. Okay, so there was a hole here. Now there is no more hole. Usually this procedure is permanent. They don't require redo operations. So they require this aspirin medicines for about 6 months. After that, they are completely cured for life. Usually no major complications are described after this, except for very, very rare and occasional aortic erosion in the long. Okay, so now this is how ASD device closure happens in the catheter. So this baby is undergoing a balloon assisted device closure. This is a balloon that I have put across the ASD, and I'm going to deploy the valve here. Okay. So now this is a fluoroscopic image. Not many of you are used to it, right? So this is how the left atrium and right atrium are placed. Okay, so I've just highlighted this to show where exactly is the atrium. Okay, so when I play it again, you see that the left atrial disc is here and the right atrial disc is on the right side. Okay, so that's how an ASD is closed. So let us hear one nice story from this mother. So there is a question here to the audience. Okay, so you can quickly type, when does a mother smile looking at her baby cry? So because all of us are pediatricians, this is a very, very simple question for you. So the question is, when does a mother smile looking at her baby cry? So I believe somebody is typing the answers. Do we have some answers? Anybody monitoring the typing?
So it's
Yeah, there are already
given
few answers.
At birth.
at baby's birth.
At birth.
Yes, very good, very good. Okay, so every mother smiles when the baby is born and crying, isn't it? So that's a perfect answer. Okay, so now I happen to witness this during the round. Okay, so look at this mother. She's crying when the child is, she's smiling when the child is crying. This is very unusual, right? So this should not happen. So why is this? Okay, so we just asked her, why are you smiling? Why can't you console your child? This child was actually just lying in one corner and crying, howling like anything. Normally, the mother's reflex is to take the baby and console the baby. She was not doing that. She's just sitting in a corner of the bed and smiling. I asked her, why are you smiling? So she said that, doctor, my child has not cried with the full voice since the baby is born. Baby was few months old. She has never heard the baby cry after the baby is born. So that is why she's smiling today that her baby is crying. Okay, so then I said, okay. Then I was thinking, maybe she's justified in crying. Why? Because this was her baby 4 hours back. Okay, so this baby underwent a cath procedure. Okay, so this baby had arrested on the cath table, and we were doing this cardiac cath procedure while giving CPR. Okay, so that means today is a rebirth for this baby, isn't it? So she's justified in crying. Okay, so now the problem this baby had was this baby had a very narrow, critically narrow pulmonary valve. The procedure what we did was called as balloon pulmonary valvotomy, where we actually float a balloon across the pulmonary valve and dilate it and open this critically narrow pathway. Okay, so this is how a blocked pulmonary valve looks like on the left-hand side. That's a balloon inserted across the pulmonary valve and dilated, so that the blocked pulmonary valve will open. So this is the procedure. So this is just an illustration about how we do this. Okay, so that's a catheter which has gone through the IVC and into the pulmonary artery. So that is the cath lab procedure. What I'm doing now is I'm going to superimpose this onto this. Okay, so this illustrations are done by my friend Dr. Ashutosh Singh, who is a surgeon, who is also happens to be an excellent artist in drawing. Okay, so this catheter now actually is directed towards this pulmonary valve here. Okay, so this is a lateral view, and I'm doing an angiogram. So this shows critical pulmonary stenosis. Once this stage is done, we just pass a wire cross the lesion, and take a balloon on this wire and then inflate it like this. Okay, so now this narrowed pulmonary valve is completely open. So when you do this procedure at such a small age, so this is almost a curative procedure. So about 10% of these patients can have a recurrence of pulmonary stenosis. So we can always do a repeat pulmonary valve. This is another baby, 40-day-old baby, referred to Jupiter Hospital with history of cardiomegaly. So child is being treated as sepsis and ventilated for a long time. They got an echocardiogram done at bedside. So somebody said that the baby has mild aortic stenosis, severe pulmonary hypertension, otherwise no other problem. So this is on arrival. Okay, if you can see the time, this is quite late in the night. It's about 11 o'clock in the night. Okay, so this patient has severe ventricular dysfunction. Ejection fraction was hardly 10%. Okay, so that's the left ventricle here, and that's the right ventricle. Okay, so this patient has severe LV dysfunction. What is the problem for this baby? This baby had severe aortic stenosis. Okay, so the echocardiographer who has done the echo has missed the severe aortic stenosis because the ventricle is so weak to pump the blood that it is not able to cause significant blockage across it, significant gradient across it. So they had underestimated the aortic stenosis. So this baby was being treated as sepsis. So this was done at night. Okay, so what we do is, again, the procedure is quite simple. So you have to just dilate this stuck aortic valve. Okay, so can you appreciate cardiomegaly here? So that is the aortic valve, that's the coronary arteries. That thin faint line is what the baby has, the aortic valve opening here. So on the right hand side, you have a balloon dilatation of the aortic. Again, very dramatic results. This was the echo in the morning, 9:33 a.m. So LV dysfunction just disappears. Okay, and again, very, very rewarding procedure. These babies will be discharged usually within a day or two after this procedure. Imagine a baby being treated for sepsis 40 days, and now after balloon aortic valvotomy getting discharged in 1 or 2 days. The lesson is, however sick the baby looks, timely diagnosis, referral, and treatment is often curative. This can be actually life-saving. So don't worry about how sick the baby is. Sometimes a miracle treatment is possible for these babies. Now look at this girl. Okay, so this is little Miss Fernandez at 10 years. So this mother keeps sharing her progress pics with us. Okay, so she belongs to Thane. So this is when she was 10 years. Can anybody guess what could be the heart disease that she has? Anyway, I'm not expecting you to type, just guess something in your mind. Okay, so this was when she was 6 years old. Okay, so she's a very enthusiastic about her Bharatanatyam. Right now, she does much more better dance than this. Okay, so she runs marathons. Okay, she's very active at school. She's one of the school toppers. So this was when she was 6 years old. Still looks okay, right? So this was when she was 1 year old. She came for the first follow-up. Okay, so this was when she was 1 year old. So this was when she was 15 minutes old. Okay, so what is this procedure being done? We are actually implanting a pacemaker for her. Okay, so this is immediately after her birth. So this was one of the very youngest pacemaker to be implanted, and we did it when we initially joined the Jupiter Hospital. So this is the same girl at 15 minutes after birth. So interestingly, this is her, okay, when her mother was 30 weeks pregnant. Okay, What is seen in this echo, this is the fetal echocardiogram. This echo shows that she has severe bradycardia. Okay, so she had a congenital complete heart block because of maternal SLE. Again, a wonderful thing about a fetal diagnosis, that this baby could be salvaged because this baby immediately required pacemaker inside the operation theater. Because we anticipated this problem, we could actually take corrective measures in the cath lab. So this case is presented by one of my colleagues, Sonia Karaputtar. Again, a case like a fetal bradycardia. Okay, I'm going to play this. It's a short video. Again, it's in the mode of PowerPoint presentation. This baby also had bradycardia, but not complete heart block. So this is a 31-year-old gravida, 33 weeks when the baby was referred. Fetal heart rate was again very low, 75 to 79. So possibilities would be respiratory distress. Any respiratory distress can cause bradycardia, or think about rhythm design. Okay, but there were no other parameters to suggest respiratory distress. I mean fetal distress. So everything else was normal. It was pure bradycardia. So once it is pure bradycardia with all other organ functions preserved, it is usually an arrhythmia. What is shown in this picture is that there is a AV dissociation, or at least there is a 2:1 heart block. For every 2 atrial beats, there is only 1 ventricular beat. That's the reason for heart block. So this baby has 2:1 heart block, and all these diagnoses are being made in the fetal echo. Okay, so cause of fetal heart block is usually maternal SLE, which is very, very important reason, 65 to 70%. So very rarely it can be congenital, or it can be long QT syndrome. So we had our thought process. Since this onset was very late in this patient, we thought it is congenital long QT syndrome. Remember, this we are suspecting when the baby is still in the fetus. Okay, so now again, a big social problem. These parents are not affordable. They cannot actually get delivered in Jupiter Hospital. They cannot continue care of the newborn baby in the Jupiter Hospital. They are not affording types. So what would be the counseling? We directed them to a place where it is affordable. So they chose to go and deliver in Wadia Hospital. And what happened to the baby? Okay, so they went to Wadia Hospital and delivered the baby. So baby was born at 36 weeks gestation, 2.3 kg baby boy. Okay, this was a ECG after birth. Okay, so this was confirmatory. As you can see, this is the QT interval. I think we have that animated ones. So this is the QT interval, very, very prolonged QT interval. Because the QT interval is so prolonged that the P wave is falling before the T wave, and this patient has bradycardia. There is not enough time for the ventricle to get activated. Not only that, as soon as the baby was born, this baby had several episodes of ventricular tachycardia. Torsade des pontis. You must have all remember, isn't it? So this baby immediately required a pacemaker implantation and initiation of beta blockers. Okay, so this is the again a second advantage of doing a fetal echo and timely intervention in this series. Okay, so now because we are all warmed up about the pediatric cardiology, I'm going to take you to a presentation of a cyanotic baby. This will be very interesting. So this is going to
We
be
have a
interactive.
question.
One
Yes, we
question was there.
Yes,
How
please.
frequently we need to revise the pacemaker?
Okay, so when you implant the pacemaker in the neonatal period, the pacemakers are usually placed on the epicardium. That means it is placed on the surface of the heart. It is not placed inside from endocardially. So once you do that, this pacemakers needs to be replaced, the first one, between 5 to 7 years of age. Okay, so when they come back for the second pacemaker, when the baby is 5 to 7 years of age, we usually implant the pacemaker through the transvenous route, like you would do it in an adult patient. So these pacemakers typically last 8 to 10 years. Most of the times, every 10 years, only the battery needs to be replaced. All the leads and everything can be left behind. And whenever you implant a pacemaker in a small baby like this, we see to it that these pacemakers are having lifetime warranty. That means the pulse generator or the battery is replaced free of cost for the baby throughout life. Okay. So once in 10 years, battery replacement, maybe once in 2-3 decades, we may have to replace the leads. In between two pacemaker replacements, child is going to have an absolutely normal life, as you saw this there. Okay. They can go to school, they can play sports, they can do everything. Okay, so life after pacemaker is not as bad as it looks. Anything else, or shall we proceed?
We can proceed,
Nothing.
sir.
Yeah. So this is a story of a cyanotic baby. Okay. So this is a 15-day-old term baby, birth weight of 2.8 kilos, born with respiratory distress, stuck on ventilator. Bedside echocardiography shows a large VSD and a truncus arteriosus. No confusion about the diagnosis. Okay. So this is truncus arteriosus. Okay. So that's the echocardiography. So what is truncus arteriosus? That means truncus means both aorta and the pulmonary artery are coming off from the common trunk. There is no separate aorta and pulmonary artery in this patient. Okay. And there is a large VSD also. Same thing is actually shown in the echocardiography also. To understand it better, so you have a 4-chamber heart, you have a large VSD here, and you have both aorta and pulmonary artery coming from a common. Okay, rest of the heart structures are normal. So what happens in truncus arteriosus is because it's a common origin trunk, both aorta and pulmonary artery have same saturation. This is a saturation left atrium, left ventricle, right atrium 60%, right ventricle 60%. But when it comes to the common trunk, both of them are same saturation. That is truncus arteriosus. What is the problem for neonatologist here? So he's unable to extubate the baby, requires very high FiO2 to maintain saturation of 95 to 100%, persistent metabolic acidosis, which he cannot treat. So liver failure, SGOT-PT in thousands. So extensive investigation for etiology were inconclusive, and hepatologist also has been involved by now. Creatinine is above 2, that means it's in terrible shape. Patient's general condition is poor, and patient is having multi-organ dysfunction. So this is the status of this baby. Okay, so and negative for septic screen. Baby is of course on antibiotics. Okay, so now what is wrong with this baby? Okay, so we just did one simple maneuver, not surgery, not intervention. Okay, one simple maneuver, which resulted in dramatic improvement in this baby. We were able to extubate this baby in 2 days' time, and there was complete reversal of metabolic acidosis, improvement in liver functions, and improvement in renal functions as well. What is it? I think some of Thane pediatricians must have heard this before, but I wanted to emphasize this case again. What is it? Any 2-3 people, if they can answer, we can wait. Otherwise, we'll just proceed with the answer. Try, even if you're wrong, it's okay. It's a very interesting concept. I think I can also see the chat. Very good. So some of them have given the answer. Okay, very good. So the answer is decrease FiO2. Okay, so just reduce oxygen saturation to accept saturation within the range of 85 to 90% and accept mild hypercarbia. So this one simple maneuver actually resulted in reversal of the whole crisis. Okay, now let us see how does it work. Okay, so as I said, truncus arteriosus is an admixture lesion. Okay, it's a cyanotic heart disease with increased pulmonary blood flow. Cyanosis happens because of complete admixture of the blood. Both saturated and desaturated blood get mixed here. Usually the typical saturation is between 85 to 95%. Okay, the saturation both aorta and pulmonary artery will be the same because it's admixture. It's a common tube that takes the blood out of this. Okay, so now when we calculate the QP by QS, that is a pulmonary and systemic blood flow, we use this fixed formula. Okay? I'll allow you to do all these things. Okay, so normally the pulmonary venous saturation is 100%, mixed venous or from the SVC-IVC is about 60%. If there is no shunt, same blood is going to go into lungs. If there is no shunt, the pulmonary venous blood is going to go into aorta. So aorta will have 100% saturation. So when we use all these numbers, we calculate what is the pulmonary to systemic blood flow ratio. In a patient who does not have any shunt, this is going to be 1:2. Okay, so this is the formula to calculate QP by QS. If somebody has a pen and paper handy, they can actually do it by themselves. So this is the formula for QP QS. Saturation aorta minus mixed venous, that is 100 minus 60. And saturation in PA minus PV, that means 100 minus 60. So it is 40 by 40, that is 1:9. So that is the formula for QP by QS. Okay, in a patient with truncus arteriosus, I told you that saturation and aorta PA are same. It is not going to be different. Okay, so what we know is pulmonary vein saturation is 100%. Aorta PA saturation is same. You just have to imagine that this mixed venous saturation is 60%. This can be variable. It could be 60, 65, and 70. So for ease of calculation, let us just take 60%. Okay. So with this information, can we calculate QPQS? I will give you a hypothetical situation. Let us say baby's saturation is 80%. Pulse oximeter saturation is 80%. What is going to happen to QPQS? Use this formula and calculate for yourself. As the first illustration, I have given you the number 80 minus 60 minus divided by 100 minus 80. Again, the QPQS is 1. Got it? All of you want little time for this? Few seconds probably we can give. Okay, so how to calculate QPQS? Okay, this is the formula that we are going to use. Okay, next slide is going to be very interesting. Okay, now replace this 80% oxygen saturation with 85%, 90%, 92%, 94%, 96%. Okay, how can you replace this? By increasing your FiO2. You keep on increasing FiO2 because this patient has low saturation. What is happening here? Can you see this right-hand column? Your pulmonary blood flow ratio is increasing. That means you are pushing more and more blood into the lungs. You are stealing the blood from the systemic circulation. That means you are stealing the blood from your brain, liver, kidney, gut, and every possible organ. You are actually causing a shock in this baby by increasing the amount of the pulmonary blood flow. Look at this. 1:1 blood flow is what every normal human being has. With 85%, it's 1.6, 90% 3:1, 92% 4:1. 94% 5:1, 96 9:1. That means you are actually causing tremendous increase in the QPQS just by targeting a higher saturation, isn't it? That's why this baby becomes so sick. Okay, so this baby is being forced to have a shock. Okay, so what should be a pediatrician's role when treating a patient with cyanotic congenital heart disease with increased pulmonary blood flow? Use oxygen very optimally. None of the babies require 100% saturation. Okay, treat all intercurrent infection. Judiciously use diuretics. Again, diuretics are also going to cause the same problem. If you give too much of diuresis, if you cause too much of fluid restriction, again, you are going to cause systemic hypoperfusion. That is not required. It should always be judicious, good balance between diuretics and fluids, okay, and optimal use of oxygen. If these babies have anemia, please correct it. So once you do all these things, once the baby is stable, please refer early for surgery because there is nothing else that we can do with medical management of this baby. Forget about a cyanotic congenital heart disease. Follow these principles even when the patient has a simple lesion like a large VSD. If the baby is admitted in your hospitals with a large VSD, with a respiratory infection or a pneumonia or a respiratory distress, do not give more oxygen for this baby. Do not give unnecessary oxygen just because the baby is having distress. Okay. So always target a saturation of low 90s in any patient who has a large left to right trend, because more oxygen you give, what will happen? More pulmonary vasodilatation will happen, and more the QP will increase. In fact, the baby is going to deuterate more and more. So at an optimal saturation of something between 90 to 95%, that is the best bet of decreasing the QP by targeting the oxygen saturation. If the baby has a VSD with a saturation of 100% without giving external oxygen, you can't do anything about it. But if the baby is requiring external oxygen, be careful not to target 100%. So target something between 90 to 95%. That is enough in most of the cases. So is this point clear? Because we are going to go to next session after this. So this is a newspaper cutting. I think most of you have seen. All of you know Dr. Satish Depujari sir. So this is a news article that he has shared. So I believe that you people have read what is there in that pack insert. Okay. So he says babies require air, not 100% oxygen at birth. This is, remember, for neonatal resuscitation also. Okay. So you need not actually push 100% oxygen in every given situation. Oxygen therapy, remember, oxygen is a medicine. As with every medicine, oxygen also can have adverse effects. Okay. Apart from your retinopathy of prematurity and bronchopulmonary dysplasias, these patients has a direct bearing on increasing left to right shunts and causing systemic hypoperfusion. Okay. So be very, very careful while we are giving oxygen in a patient with heart disease. If a patient has left to right shunt like VSD and PDA, low 90s is an okay saturation. The baby is sick in ICU. In a patient with tetralogy, all of the right to left shunt, target of saturation is 80 to 82% is good enough. You do not need more than this saturation. In an admixture lesion, your target saturation should not exceed 90%. Admixture is one, what I talked to you about, like truncus arteriosus or TAPVC. If you target for more oxygen, you're going to cause more harm. Okay. So I think this message is clear. Okay. If any questions, we can take a break here, solve this, and then go to the next session. So far, no questions in the chat box. Okay, shall we go to the next session?
Yes, sir.
Okay. So this is a presentation about a child with severe ventricular dysfunction. Again, many of you would have seen children with severe ventricular dysfunction, right? So is it a cardiologist's problem or is it a pediatrician's problem? Actually, it is a shared responsibility. It is both of our problem. How can a pediatrician make a difference? Okay, because once LV dysfunction diagnosis is made on echo, what can a pediatrician do? So if you have a good cardiologist with you can go back to him, discuss with him. Most of the pediatric cardiologists have very good knowledge about pelvic dysfunction. They are going to give a solution to you. If you do not have an access to a good pediatric cardiologist, can you make a difference? That is what I'm going to show you now. Okay. So now this is a set of 6 echocardiographies. All are 6 different babies. Okay. So I think you people can make out that these babies have severe ventricular dysfunction. Okay. So this is all left ventricle, left ventricle, left ventricle, left ventricle, left ventricle. So you can grossly make out the pumping of these ventricles is not good enough, right? So this example we've already seen in the previous slides. So all of them have severe LV dysfunction. Okay. The LV dysfunction and each and every baby is not more than 5 to 10%. The question is, how many of them have survived? Any guesswork? Out of 6 babies, how many have survived? You can just type a number. Okay, you can be completely wrong or you can be completely correct. Just guess a number. 4, okay, 6, all great, 3, great. So yeah. So as I said, it's just a guesswork because this much information is not enough to diagnose LV dysfunction or treatable or non-treatable LV dysfunction. That is my point also. Just based on echo, you cannot know whether this LV dysfunction is treatable. What would be the line of treatment? Is a cure possible? Okay. So these patients require extensive workup. One of the most important workup is what we are going to discuss today. That is what a pediatrician can do. Okay. So these are all the reasons of reversible LV dysfunction. Any structural heart disease. You saw the example, aortic stenosis. If you relieve it, baby will have a completely normal life. Is one of the most commonly missed causes of LV dysfunction in a small child. Child with coronary anomalies, for example, Al-Kappa is very, very commonly missed on most of the echocardiographies. Tachycardiomyopathies, that means increased heart rate induced LV dysfunction. They can cause severe LV dysfunction. Hypocalcemia, completely reversible. Again, uncommon nowadays. It used to be very common a few years back. Children with hypocalcemia presenting with cardiomyopathy and repeated seizures. You treat hypocalcemia, all cardiomyopathies are reversed. Okay, pre-excitation cardiomyopathy. That means these patients have WPW syndrome. Because of undiagnosed disease, these patients do develop cardiomyopathy in long run. Pompe's disease. All of you know what is Pompe's disease. Glycogen storage disorder. Kawasaki disease. We have seen enough number of cases because of MISC episode. Takayasu arthritis. Very, very common disease. All other causes. Luckily, others are all very, very uncommon. Okay. So, you know what is the beauty of all this? You can diagnose all these things by just doing an ECG. Isn't it wonderful? So apart from an echocardiography, you can make a diagnosis of all these lesions by just doing a simple 100 rupee investigation called as an electrocardiography. This is where a pediatrician can make a difference to this child. You identify the cause, treat the cause. These children are completely treated for life. Okay, so I'm not going to go into each individual disease today, but I just wanted to make a diagnosis of this. Okay, these are the examples of coronary artery abnormalities. Many of you are aware of Al-Kappa post-Kawasaki. So coronary arterial fistula is a rare diagnosis. Coronary arterial ostial stenosis, rare diagnosis. These are common coronary anomalies which can be treated. All of them will have ECG abnormalities. Okay, so you can pick them up on the ECG. That is the importance of doing an ECG. Now, common question, all of you would have already thought in your mind, you do not have an ECG machine. Even if it is there in our hospital, we do not have any pediatric specific equipment. Again, my point is to specify this and solve this problem. Look at this ECG machine. Where is this ECG machine? This ECG machine is there in Jupiter Hospital. Is it a pediatric ECG machine? No, this is not a pediatric ECG machine. This is a standard adult ECG machine that we are using to do an ECG in a child. How do you convert this into a pediatric ECG machine? You just are going to remove all these clamps and suction bulbs from this, okay, and put these electrodes directly onto the child's chest wall after applying some electrode jelly. Okay, So you apply this micropore tape on this. You need not actually use this. Okay, you can do an ECG even in the smallest of the baby. So this is a small newborn baby ready for cardioversion. See this, we have already attached a cardioversion paddle on this baby. We are about to do a cardioversion. Even in this baby, an ECG is possible. Okay, so we have already converted that adult ECG machine into a pediatric ECG machine. Okay, so how to do an ECG? Very, very easy. You can train your nurses. Okay, so most of the ECG machines have instructions about how to obtain an ECG. Okay, so is it an expensive? Okay, see the comparison between the cost of an ECG machine. These are all commonly available in market. If somebody is willing to purchase an ECG machine, at least buy a 6 or 12 channel ECG. Do not purchase a single channel ECG machine because making a diagnosis with that is extremely difficult. Minimum will be 6 to 12 channel ECG. So they are on an average cost about the cost of an iPhone. Okay, so I'm sure 30-40% of the audience today who are sitting here have a proper iPhone. Okay, so if you invest that much money into the ECG machine, even if you save one life, the money is worth it. Okay, so you cannot suddenly do an ECG one fine day. You have to get used to doing an ECG. So keep on doing an ECG. What are you going to do with these ECGs? If you cannot interpret these ECGs, please send these ECGs to any of the pediatric cardiologists. Okay. If you want to send the pediatric ECG to a nearby pediatric cardiologist, send it. Even if you want to send it to us, you send it. We are going to report on this ECGs and we are going to guide you for this. Okay. So this is only till the time you people learn how to read ECGs yourself. So IAP is again coming up with a national module to train the pediatricians for learning ECG. So the program is being made. We are going to conduct this ECG training module throughout India very shortly. This is going to be an online module. So please join for this module. We are going to come give you the information about this in subsequent weeks. Okay, so this is going to happen in Basavaraj sir's time. Okay, so we'll try our level best to save all these children. Okay, so using this, okay, I also want to give you one more important message or a lesson from these children. Okay, so this is a small baby, 16-day-old newborn baby. Okay, so who is unwell, has a heart rate of 280, RR of 50, activity color perfusion is good, unremarkable except for tachycardia CVS. Okay, so liver is palpable, 4 centimeters. So probably this baby has a heart failure. Okay, so what are the pointers to arrhythmia? Heart rate, which is very, very high, is a pointer. Okay, CVS unremarkable except for tachycardia is a pointer. So child in heart failure is a pointer for tachycardia. Okay, so these are all the markers. So an ECG is being done. So what I'm displaying is a 6-channel ECG. What you can grossly appreciate is this patient has severe tachycardia. Okay, the heart rate is almost 300 beats per minute. Okay, as I told you, today we are not going to elaborate on tachycardia and management. I'm just wanting to tell you one single point. Okay, so this much amount of diagnosis, I think most of the pediatricians can do. They can do an ECG, they can identify narrow QRS tachycardia, so they can diagnose SVT. Yes, no. Okay, so once you do this, what are you going to do? This is again from your pals. Okay, you follow this pathway. Okay, here, this comes here. The child is relatively stable. Okay, you can consider giving adenosine. Okay, most of you know that the treatment for adenosine, SVT is adenosine. Okay, so apart from adenosine, in a bigger child, you can do all these things. Do carotid sinus massage. So put a cold pack on the face, blow through a straw if the child is cooperative, ask the child to inflate a balloon. All these are mimicking Valsalva maneuvers. Or if you do not have adenosine, you can always do DC cardioversion. It's a very safe procedure to do. Okay, you can also give adenosine. Okay, the reason for presenting this case is to discuss with you about adenosine. Okay, adenosine will be useful for both diagnosis and treatment. Okay, so let us take this and then go for questions if there are any. Okay, so now this one is going to be a completely interactive session. I want maximum people to participate in this because there are so many myths about adenosine. Okay, so I want to clear all of them today. How many of you have used adenosine? So just say yes, no, tick, whatever you want to say. So when I ask this question in a common forum, at least 20 to 30% of the audience would have used adenosine sometime in their life, especially when you have sufficient seniority. So many of them do have used adenosine. Okay. So yeah, here also I think many of them have said yes, no, no, yes. Okay. So let us say this forum also has 30% experience of using adenosine. Okay. So next question is, Where do you store adenosine? I would like this to be answered. Okay. So these are different compartments of the refrigerator. Okay. So starting from the door handles, which is number 5. Okay. So number 4, lesser temperature, 3, lesser temperature, and 1 is the deep freezer. Where do you store your adenosine among these 1, 2, 3, 4, 5? Okay. So let's see how many people answer and what is the most common answer. Just type 1, 2, 3, 4, 5. Where do you store adenosine? So this is going to be interesting. Okay. Where do you store your adenosine? 2, 2, 2. The most common answer is 2. Okay. So let us say majority are going with 2. Okay. So remaining of them are saying 5. Of course, nobody will say deep freezer. So others will agree on 3 or 4. Okay. So now let us see the package insert of adenosine. Okay. So this is a package insert of adenosine. Can you all read what is the storage information for adenosine here? I just enlarged that. What is the storage information for adenosine here? It says 20 to 25 degree centigrade. Okay. So where do you get 20 to 25 degrees centigrade in the refrigerator? Nowhere. Okay. So now go back to your ICUs, go back to your units, find out where that adenosine is kept. If it is kept in refrigerator, please instruct your nurses not to keep it in refrigerator, because frozen adenosines, the one which is kept in refrigerators, do not work. Okay. They get disabled. Okay. So they are not stable at a lower temperature. They always have to be maintained at room temperature. So what is a proper place to store adenosine is not the refrigerator. Proper place to store adenosine is your emergency drug cart, which is kept inside one of the ICUs. ICU temperatures are ideal for keeping adenosine. Okay. So do not exceed 27. Okay. So do not come below 15. So it has to be stored under room temperature. Okay. This is one of the most common reasons why adenosines don't work when you give. Okay. So why we get frustrated after giving adenosine? Adenosine not working. Adenosine not working. Otherwise, adenosine has to work 100% of the time. Okay. What is the dosage of adenosine? Very simple question. Okay. So 0.05 milligram per kilo. I know some of our resident doctors give this because they are scared to give adenosine. Okay. Even though it is not a recommended dose, they'll start with very, very tiny dose. So usually nothing happens with those. 0.1 milligram per kg. Most often this also does not work. Okay. Take it from me. We would start a dosage of 0.2 milligram per kilo. Okay. So this is a good starting dose. Okay. This is the first dose I'm going to give for my patient. If this one doesn't work, this is the dose that I'm going to give for for my patient as a second dose. Usually we do not exceed this. What does most of the recommendations say? The most of the recommendations say give at a dose of 0.1 to 0.3 milligram per kilo. Okay, so 0.1, in my experience, most often it doesn't work. So we start with 0.3 and go to 0.3 milligram per kilo. What are we afraid about adenosine? We are only afraid about apnea, right? We are only worried about a hypersensitive reaction. Okay, so if you are giving adenosine in a ICU setting, usually you can tackle this. You just have to be ready for resuscitation. Okay, so but do not give a smaller dose of adenosine because it just does not work. Okay, so now what happens if the patient has an apnea, patient has an adverse effect of adenosine? How long does it last? Okay, the question is, what is the half-life of adenosine? Okay, quick 1 or 2 answers. After that, we'll go on to, yeah. So somebody has said 10 seconds. Very good. Okay, so 5 to 10 seconds is the correct answer. Okay, so that is the duration of adverse effect of adenosine also. You just have to tide over that short duration of time. If the patient has developed apnea, you just have to do a CPR, intubate the patient. Babies will come back. We have not lost a single baby after giving adenosine so far. We must have given hundreds, if not thousands. Okay, so because the half-life of adenosine very, very short. So half-life of adenosine definitely good for adverse effect. It also has one bad effect. What is that? Okay. So the reason for such a short half-life of adenosine is because it gets metabolized inside the red blood cell. Okay. It did not reach any target organ. It did not reach your liver. It did not reach your kidney. Nothing. The minute the adenosine comes into contact with the blood, it acts with RBCs and gets metabolized instantly within the blood itself. Okay. So that is another reason why adenosine fails. Why? Because if you give adenosine at a very, very farther away site, like if you give it in the foot vein, by the time it reaches the heart, the adenosine is all metabolized, it's useless drug. Okay. So if you dilute adenosine and give it, again, same problem. Over dilution will cause mixing with the blood, again, it gets metabolized. Okay. If you do not give adenosine with a rapid bolus, okay, it will not reach blood. If you just give it slowly or if you just give it fast, it won't reach. You should always follow it up with a 10 cc saline rapid bolus. Okay, then only it will reach the target organ, which is the heart. Do not draw the blood into syringe. All of us have that habit of aspirating to remove the air bubbles. Okay, if you do that, the metabolism of adenosine starts even within the syringe itself. Okay, do not draw the blood into the syringe of adenosine. Just have to tear the port and give adenosine directly. Use the largest size cannula possible. Okay, if the child is big, use that advantage. Put a bigger cannula and give adenosine closer to the heart. Okay, so preferably central line, but otherwise at least a brachial line. Okay, so do not give it in any of the foot veins. Okay, when you do an adenosine, please record the response continuously. Okay, so then only we know whether the adenosine has acted or not. So sometimes the action of adenosine is so transient that you will miss the response completely. Then you will say that adenosine has failed. Okay, so this is how you give adenosine. Take adenosine in one syringe, push it rapidly, immediately follow it up with a 10 cc saline push. Okay, take a three-way, push this and push this. 1, 2. Okay, this has to happen within seconds. Okay, so if somebody asks you how will you give adenosine, do not say I'll push it fast. The correct word is I'm going to push it rapidly. Okay, then only it is going to work on your patient. Okay, so adenosine just works predominantly on the AV node. Okay, so what it does is it transiently inhibits the conduction of impulse across the AV node. That means it causes a temporary heart block in the patient. Okay, so what is the response to adenosine? Three things. One, there can be sudden termination of tachycardia. That is, the tachycardia is cured. Okay, so patient, if they has AVNRT, AVRT, the tachycardia is cured. It can have slow and unmasking. That means it will act temporarily, but it does not cure. So this has a diagnostic value. Okay, patients with atrial flutter and atrial tachycardias will have slowing of tachycardia, but again the tachycardia will come back. So this has a diagnostic value. Sometimes it has no effect at all when you give. If you give it properly in all the points that we have discussed. Okay, this can happen if the patient has sinus tachycardia. If the patient has junctional ectopic tachycardia, patient has tachycardia below the level of the atrioventricular node. Okay, so whether it acts or does not act, if you have done it properly, then you have a diagnosis of giving adenosine. Okay, we gave adenosine to our patient. Okay, see what happens. There is a sudden termination of tachycardia. Heart rate of 300 has become 100. Okay, so the patient has instantly got cured. Of course, we need to follow up these patients by giving them more medicines. Okay, so we will usually put them on either digoxin or beta blockers. Okay, so one of these antiarrhythmic agents once the tachycardia is terminated. Okay, so now this ECG also has one more very beautiful clue. Okay, it may be very difficult and time taking for you to find out, but if there is somebody who has an orientation of ECG, can you point out what is the additional diagnosis in this ECG? So this is the ECG during sinus rhythm. Okay, so there is nothing abnormal with the rhythm. Rhythm is all sinus, PQRS, everything is beautiful seen. There is another very important clue hidden in this patient to give diagnosis why this patient had tachycardia. So can anybody attempt? Maybe we'll just wait for 15 seconds and then go ahead. If somebody wants to attempt, otherwise we'll go ahead. Now, Bhavish Mithya has answered, but okay. Very good. So some of you have answered. Beautiful. Okay. So that is delta wave. Okay. What is delta wave? Delta wave is a pre-excitation wave. Okay. Where is delta wave? Delta wave is here. Okay. So you see the P wave and the QRS. There is no gap at all between the P and the QRS wave. The QRS immediately starts off even before the P wave ends. So this upsluring of initial QRS complex is called as a delta wave. Okay. This happens whenever there is a short circuit, whenever the electrical activity finds an alternate path for the impulse to travel from the right atrium to atrium to ventricle across the short circuit. Okay, so these are all delta waves. Okay, so this patient's complete diagnosis is perfect. Okay, somebody already said, so this is WPW syndrome. Okay, so with atrioventricular reentrant tachycardia. Okay, fantastic. So adenosine is a very, very powerful and effective tool, provided you store it properly, use it properly. Okay. So I have never seen an adenosine fail in my experience. Okay. It will always, almost always work. Suppose your adenosine does not work and if the patient has SVT, do not hesitate to give TC cardioversion. Okay. That is also equally effective. Okay. Right. So now a little bit relaxed mood. I'm going to show you a small movie. Okay. So this is the movie about this brave boy. Okay. So who had a problem, who had a PDA. He was only 900 grams when we did this PDA device closure. And this is latest. He's now 6 years old. Okay. So I'm going to take you through a small video. And again, of course, this was one of the smallest baby we implanted in the entire country. This happened 6 years ago. Okay. So now this is Shiva's story. Okay. Can you hear the sound in this audio? Do you have the audio playing along with this?
No, sir.
Yes, yes, sir.
Yes. Okay. I've just paused it now. So if the audio is visible, then I'll replay it.
No, sir, no audio.
Sorry?
No audio, sir.
No audio. Okay. So what do we do? How do we get this audio?
Mm. Sir, you can reshare the presentation with click on the share sound button.
Okay. Let's do that because it's an interesting one.
Okay. Just stop sharing.
Hmm.
While sharing, there is option of share sound. Just click on that, sir. I think sir has left, sir.
He'll rejoin or what has happened?
Yes. I think by mistaken he has left the meeting.
Just a second. I'll talk to him.
So Dr. Srinivas has left and he has rejoined, so he has to be unmuted.
Yes, done, sir. Done. He's co-host now. Sir, kindly unmute yourself.
Yeah, done. Okay. So let me share the screen again.
Yes, sir. While sharing,
No.
click on the share sound button.
Where is share sound button?
It is on the right hand side. While share, you click on the share screen button. But
I don't think so. It has happened.
no, we cannot see your presentation bit, but we can see your like browser. Just
Okay.
minimize it, sir. Yes, now presentation is visible.
Okay.
No, again it is disappear.
One. I can't have that sharing button actually. Sound share button is not there.
It is not there.
Yeah. Okay. So if sound share is not happening, let us not have it. Let us go with the other things. Okay.
We'll try once again, sir.
Once again. Yeah.
Yes, sir. Please.
No, right?
Yes. We can see video.
But no sound.
No sound, sir.
Okay. So let us not do this. Okay. So this is about how this baby underwent a PDA device closure. Okay. So the father, it's a very beautiful video, very touchy video that has been made by the father. Okay. So we did this about 6 years ago. Okay, so this was our first experience. Okay, so first time in India that we did 900. So once this happened, many more Shivas followed. Okay, so all these babies are different babies who undergone PDA device closures. Only a few of them we have clicked the pictures. Okay, so now we have done more than 25 patients under 2 kilos. Okay, so Shiva was 900 grams. The smallest now for us is 680 grams. Okay, the weight range is from 680 to 1900 grams. More than 15 of them are less than 1 kilo. The day of intervention has been performed on day 26. The average is actually very, very late compared to developed countries. The average day of intervention that we do for PDA is 26 days. That's quite late. The average day of intervention in most of developed countries is 7 to 10 days. Okay, that means, of course, in our situation, the referrals, the decision to do a procedure, multiple the paracetamols and ibuprofens, all those things are being tried even before we start to think about doing a PDA device closure. That's the reason for late reference. Earliest we have done is 7 days, and latest we have done is 55 days. So this we were able to do because we have a vast experience of PDA device closures. More than 880 patients have undergone PDA device closures in Jupiter. Even under 2.5 kilos, there are more than 50. Under 5 kilos, there are more than 280 patients without experience. So we could actually translate all this experience into doing smaller and smaller babies. So how did it help us, and what could we do? Okay, so this is one of the babies was 760 grams. On day 39, he was just 830 grams. Okay, this baby just could not actually get off NIV or oxygen. He was oxygen dependent. 2 doses of paracetamol has been given on day 10 of life. I mean, 2 courses have been given from day 10 onwards for close the PDA. But he continues to have a STOMI course. He survived sepsis. He had NEC, etc. Still required NIV support. So this is one of the typical cases that we get, a very late referral for duct closure. Okay. So we were again called back to see this patient because the baby had a reappearance of murmur on day 13. Okay, so this is very exciting, mostly a technical case. Okay, this was a cardiomegaly the baby had. Okay, so this dilated left atrium and left ventricle. Okay, so what is measured here is all the left ventricular dimensions. Okay, so when you want to know what is the normal left ventricular dimension, there is no reference actually for these babies because they are so small that there are no reference. So we have to actually fall back upon some of the published literatures about the preterm babies. Especially for babies who are less than 1 kilos, there is hardly any literature. So how do we know that this baby has LV dilatation is by all these charts. Okay, so this is a picture of a patent ductus arteriosus. This red flow, what you are seeing is a large PDA. Okay, so this baby has a large PDA. Okay, so now many of you cannot recognize PDA in this picture. I can understand. Okay, so be with me. So this is the left pulmonary artery in this baby, and this is a patent ductus arteriosus. So look at the shape of patent ductus arteriosus. This entire patent ductus arteriosus can be beautifully seen on echocardiography. So the cardiologist can plan a device closure in these babies. Okay, so these are all various measurements that we do. Okay, all these are measurements of the PDA that we are doing. Remember, all these things are on echocardiography, so no other investigation is required. So this is on a bedside echocardiography machine. The picture on the extreme right shows the entire shape of the PDA. Okay, so it's all there in a tiny dotted line. This is the entire PDA in this baby. So once we have this much amount of clarity, we can appropriately choose how to do this PDA. So that's the outline of the PDA. So the entire PDA can be beautifully seen on an echocardiography. That one. So this is how we place a device in this baby. Okay, this is a PDA device. Okay, so typically this PDA device is very, very tiny. In this patient, it is about 5 into 4 millimeters. So that's the size of the PDA device being held on my hand. That's compared to a nickel. Okay, so now all these things are not going to elaborate too much how we do it. So we usually take a femoral venous access 4 French sheet, very tiny sheet, and we use all this hardware. Okay, so the most standard device that we are going to use is an Amplatzer Piccolo device. So the brand name. And how are we going to do is this is how we are going to do. We are going to put access femoral venous puncture. Okay. So as I said, this is an exceptional baby. So we took this baby for procedure. I'm trying to access the femoral vein here. You see what's happening? The wire does not go inside. I do an angiogram to see what is the problem. There is no patency of the femoral vein at all. Okay. So there is no continuity of the iliac vein onwards until the infrahepatic portion of the IVC. Entire thing is a mesh of collaterals. So right side is gone. You can't do any intervention to the right femoral vein. Okay, so then I took a puncture on the left femoral. Okay, luckily we got punctures very quickly in this baby. Left also same situation. That means access to heart is gone. You cannot access either of the femoral vein. Okay, now this is the real challenging case. Okay, so this is a little bit of an etiopathogenesis. This all we have read it after we have come out of the cath lab. So there is a described entity called as complete absence of this entire segment. Okay, extremely rare. Unfortunately, this baby has a PDA, needs to undergo a PDA device closure, and has this anomaly. Okay, so what are you going to do? So what we did was we did this PDA device closure through transjugular access. Okay, so here the baby is reversed in position. Normally the head end is on the other side, foot end is on this side. We reverse this tiny baby on the cath lab. Okay, and we started doing this procedure through the jugular venous puncture. Okay, so you see what we have done is I put a cannula through the jugular vein. Now I am actually across the pulmonary artery here. Okay. In the second picture, I'm crossing the PDA. Okay. This is all done in cath lab. Okay. This wire now will go into the PDA. I've crossed the PDA. So this is jugular vein, RA, RV, main pulmonary artery, PDA, and then into the listening secure. Okay. This has gone across the PDA. Okay. So now once I have a stable position of the PDA, I do an angiography. Okay. So this entire length is a PDA. Okay. So this is how the PDA looks like. Okay. So there is the aorta, there is the PDA, and there's a pulmonary artery. Okay. To understand what is being shown on the fluoroscopy image, I'm going to superimpose this picture. Okay. So that is the PDA for you. Can you make out? That is the PDA for you. Okay. It's a long length tubular PDA in this baby. Okay. So that is what we are going to close. Okay. Right. So now these are all the intervention procedures. That's the PDA. That is the frozen image of the PDA. That is the illustration of PDA, and that is how it looks on the echo. Can you see that all these pictures are more or less same? Okay, so that is the beauty of planning for a PDA. Okay, how a device is done? Okay, device is implanted within the duct. Okay, so the device is being taken here. That's a fluoroscopy image. Okay, I'm trying to place the device well within the ductus here. So you see, this all requires highly accurate placement of this ductus, because this needs to be there inside the completely inside the ductus, not in the pulmonary artery, not in the aorta. This device is made in such a fashion. Okay. Now the PDA device closure is done. Okay. So this is a PDA that has been implanted. Okay. So it is quite a challenging case. Okay. So that is how it looks after the device closure is done. That's the PDA device flow in the aorta, pulmonary artery. Okay. So this is an immediate X-ray of this baby. Can you recognize that congestion has come down? Even the cardiomegaly has come down. So this is after shifting this baby to the ICU back. Okay. So this was one of the first babies to undergo a transjugular PDA device closure, not only in Jupiter, but in the entire country. So Shyam Sadanandam is one of the proprietor of this PDA device closure. He's a basic inventor of Piccolo device. Even they also have very few cases done transjugular access. Okay, so it was a moment for celebration. You can recognize many of us, that's Parmanand, Sonia, Nilesh, Dilip Chavan, and Mahesh. This is our team. Okay, so now after this, even before your enthusiasm dies, I'm going to present one more diagrammatically opposite case. So if there are any questions, can we take them now before we go on to the second presentation?
So we have a question.
Yeah.
Please guide regarding approach to neonatal bradycardia.
Right. Most commonly, the neonatal bradycardias happen because of the heart block. Okay. So if it is because of congenital complete heart block, whatever the reason, okay, whether it is SLE, congenital complete heart block, okay, so these babies do require pacemaker. If the babies have a heart rate of more than 60 to 70, they don't require pacemaker, especially if the baby has hemodynamic stability. Okay. So if the heart rate is less than 60, or with a heart disease, if it is less than 60 with heart disease, less than 50 without heart disease, these babies will require pacemaker. Okay. So with a complete heart block, you cannot actually increase the heart rate by giving any medicine. Okay. Like giving isoprenaline, giving atropine will not increase the heart rate, because the etiopathogenesis of this bradycardia is complete heart block. Okay. So if the heart bradycardia is because of long QT, okay, it is even more difficult problem to deal with. Not only pacemaker, these babies will also require implantable cardioverter defibrillators. Okay, it is a much more difficult problem. Okay, so bradycardias, which you commonly see in your practice, are all sinus bradycardias. Okay, sinus bradycardias do not have a etiology in heart. sinus bradycardias are always external to the heart. What are the common reasons for sinus bradycardia that you encounter in your neonatal practice? One of the most common reasons is hypothermia, hypothyroidism, raised intracranial pressure, sepsis. Okay, all these causes are outside your heart. Okay, so the primary pathology for bradycardia is not inside your heart. Okay, so you cannot actually treat this bradycardia by manipulating the heart. Okay, you treat the primary cause, your primary bradycardia is all treated. Let us suppose you have bradycardia because of some other reason. Let us say increased intracranial pressure and you have bradycardia. You have hemodynamic instability. These bradycardias you can treat temporarily by giving medicines. All sympathomimetic drugs like atropine, isoprenaline can transiently increase the heart rate in these patients, allow you to make this baby stable so that you can treat the primary pathology. Otherwise, primary bradycardias require pacemaker, secondary bradycardias require treatment of the cause. Okay, am I clear? Any other questions? Okay, indications of open duct closure. Even today also, for every PDA device that we are going to put, there are at least 20 babies who are undergoing duct ligation. Okay, so duct ligation is a surgical procedure. Okay, so surgical ligation of PDAs have been happening for ages. For the given baby, for the given situation, duct ligation is an equally good procedure. Okay, so there are many babies born in rural areas. It is difficult to transport them to a center where they can do a PDA device closure. So for them, the best possible option is to get a surgeon who has an experience in ligating the duct, get it ligated at bedside. Okay, so this is the safest procedure for the baby. Only babies who have access to cath lab, who have an access to a cardiologist who can do this PDA device closure, you have this luxury of doing a PDA device closure. Advantage of PDA device closure is shorter recovery time and avoidance of other complications which are commonly seen with your PDA ligation. But again, the training, expertise, and the cost, all of them are quite high for a PDA device closure. Okay. If you have an access to a good surgeon who ligates the duct, there is absolutely no contraindication for PDA ligation. Please go ahead because it's a life-saving procedure. I have had one very bad experience of a baby getting shifted all the way from a very remote areas of Maharashtra. I'm not going to name which one. In spite of telling the local doctors there not to shift the baby because the baby is only 900 grams, already has NEC, they shifted the baby from the rural area till here. The baby actually arrested on the way. Okay, it is extremely difficult to shift these babies who are very fragile, who are very tiny, who are on ventilator to a center for device closure. Okay, it is almost impossible. Okay, this procedure is possible only within the city where a pediatric cardiologist is available. You have a PDA, you have a surgeon. Either you call the surgeon to your city, get them ligated at the bedside. That is the safest thing to do for your baby. Okay, am I clear with this?
Yes.
Yes, sir.
Okay, right. So are there any conditions to preserve the PDA is the question. Okay, fantastic. Okay, so that is the next case which is already on the PowerPoint. A case to keep the duct open. Okay, so most commonly. Yeah. So yes, there are certain situations where you need to keep the duct open. Okay, so this is one such example. So timely somebody asked a question exactly. So this is a 1.29 kg preterm baby who was born of IUGR in a government hospital. Diagnosis tetralogy with pulmonary atresia. Okay, so what is tetralogy with pulmonary atresia? So tetralogy pulmonary atresia means there is tetralogy and there is complete absence of flow from the right ventricle into pulmonary. There is totally disconnected flow from the right ventricle into the pulmonary artery. So this is called as a duct-dependent circulation. You need to give prostaglandin infusion to keep this ducts patent in these patients. So, okay. So all situations, duct-dependent circulations, you need to give. You need to keep this ducts open. So when you give prostaglandin, this will be open for transiently for a few days. Okay, typically 7 to 10 days. After that, it becomes resistant. It starts closing. Okay, so this is the baby who was in this situation where we did something very interesting. Okay, so this baby has pulmonary atresia. If you have pulmonary atresia, blood will not flow into the lungs at all. So where will the oxygenation happen in the baby? So you need to keep the duct open. So maintaining of patency of this duct is very important. Okay, this is the echocardiography. It's a typical tetralogy of Fallow. There's a large VSD here, and there is no pulmonary artery at all. Only aorta comes off from the right and left ventricle. Okay, So that's a very constricting PDA which is on prostaglandin. Okay, so that is a duct. So that is the PDA which actually inserts into the duct here. That's aorta, and those are the pulmonary arteries. So this is the echocardiography. If you're not getting echocardiography, don't worry about it. Okay. So normally what we do for a patient who is duct dependent and who is already past few days for a longer maintenance of patency, we usually typically do BT shunt. Okay, BT shunt is what all of you have heard. Okay, so of late we have been more and more doing cath lab palliation called as PDA stenting or RVOT stenting. That means we go and open up the RVOT, put a stent and keep them patent. Okay, this is in lieu of BT shunt. Okay, it works as good as BT shunt with lesser morbidity and mortality at times, and it also provides palliation for say about 3 to 6 months time. Okay, so by then the baby would have grown up and they would be suitable for complete repair or next stage surgery. Okay, so when you do BT shunt in a preterm babies, the problem is the size of the vessels are so tiny. This 1.29 kgs, it's almost impossible to do a BT shunt in this baby. Okay, because there are very high chances of shunt occlusion. Okay, so as I said, one of the alternative is RVOT stenting. So this is one of the babies with tetralogy fallow. Okay, that's the right ventricular outflow tract. Okay, so this thin line, what you're seeing from right ventricle into pulmonary artery is the RVOT. So you see that we have placed the stent here across the RVOT. Okay, so this much amount of blood flow we have increased. Okay, so this can be done, but this baby has pulmonary atresia. This is not suitable. So we do something called as duct stenting. Okay, so this is the aorta. Okay, so you saw the PDA device closure. Now we are going to keep this PDA open in this baby. So this is a thin line that takes blood from the aorta into the pulmonary artery because it's a constricted duct. In the second patient, you can see we already placed the stent. Okay, so this is duct stenting procedure. Again, we have done plenty of duct stenting procedures of late. Okay, so this is the world over experience. Many papers are there. Just summarized one. Many of the centers now completely shifted from doing BT shunts regularly to doing this palliative procedures regularly. So this has been the experience in some of the centers in India as well. Okay, so this is all the evidence for this. But duct stenting in a very low birth weight baby is extremely challenging. Okay, so hardly we can see any referrals or references. Okay, so some of the papers, even the Indian experience, some of them have done this duct stenting in babies as low as 1.97 kgs. But this 1.29 is exceptionally very low. Why? Because we don't have access to any of the arteries. All the arteries are so tiny that you can't insert the catheters and sheaths. No femoral artery, no axillary artery, no femoral venous approach. Okay, size of branch pulmonary arteries are very small. You don't get appropriate size, length of the stents. Let us say I want a 15 millimeter stent. I need to have 15 millimeter. I can't put an 18. I can't put a 10. You need to have a 15 millimeter stent. Okay, so all these are the problems, and there is absolutely zero margin of error. Let's suppose there is a problem while deploying the stent. Something happens to the stent. I place it too deep in or I place it too before the desired position. There is instant death of the baby. Not even the surgeon can salvage the baby. So that is a high risk. So we had to counsel this patient a lot. Actually, we did a lot of negative counseling for not getting this procedure done. But the parents were hell-bent upon getting this procedure done. We took our surgeon also into confidence. Okay, and finally, we went ahead and doing this procedure. We had to stop prostaglandin and allow the duct to constrict so that the stent will be in a stable position. By the time we started doing this procedure, it was already 11:30 in the night. Okay, so this is the procedure. As you can see, I've taken the puncture via the carotid artery. Okay, because there is no other access possible for this baby. Okay, this is a direct carotid artery puncture. We puncture carotid arteries with a 24 gauge cannula. Once you are in the carotid artery, the tip of this wire is in the ascending aorta here. Okay, so that is what is shown in this picture. Okay, so now I told you that we are going to stent the duct. So this is the PDA here in this baby. Okay, so can you make a PDA on the angiography? If not, I'm going to impose this picture onto this. So that is anatomy. Okay, these are the branch pulmonary arteries, ascending aorta. This is the left common carotid artery through which the sheath has gone inside, and that is the ductus. Okay, now I am planning to put a stent from this point to this point. Okay, so what we do is we put a wire. Wire usually goes in very straight because it's a straight pathway. Now this wire is from the carotid artery into the ascending aorta and across the duct into the left pulmonary artery. Okay, so the second picture shows putting another wire into the right pulmonary artery. Okay, so the third picture shows wire in both the pulmonary arteries. Okay, we do an angiogram to decide from where to where deploy the stent. Okay, so this one shows daughtering with the balloon. I'm just measuring the perfect size of a stent by putting a balloon. We are not dilating it with a balloon. We are only measuring the size. So this is a 15 millimeter balloon. Okay. So now what are we going to do? We are going to take the stent. Now this is a stent placement procedure. Okay. As I told you, it requires extreme caution to place this stent. Okay. So now the stent is in perfect position. You see immediately the pulmonary blood flow increases after placing the stent. Okay. It is as good as doing a petition. Okay. So this baby had fantastic flows in the pulmonary arteries after the stent procedure. So baby, in fact, went back to the referring NICU within 48 hours. Okay. So no prolonged intubation required, nothing. After that, the baby has grown steady weight. Even branch pulmonary artery growth is good. So because the stent is very, very small, because the baby is small, they would require an immediate surgery within next few months of life. So what is the lesson learned? Okay. Yes, of course, it's rare, fantastic procedure. All those things are good. Okay. So lesson learned is cardiac surgery intervention need not wait for an appropriate weight. Okay. So when people say that the baby should require minimum 5 kilos, minimum 10 kilos, do you think such babies will ever reach 5 kilos and 10 kilos? They never reach actually. Okay. So what is required is for these babies to reach a place where an appropriate assessment is being done and an appropriate suggestion is being done. As of today, there is no weight criteria to operate any baby. If the baby requires surgery, baby requires surgery. Okay. So if not, we can always come up with a solution. Okay. Do not ask any of your babies to wait till the baby becomes 5 years, wait till the baby becomes 10 years. Okay. That is not valid anymore. Okay. So even a suitable patient, not in all patients. Tomorrow, if another 1.29 kg baby comes, I may not be able to do this procedure if anatomy is not suitable. At least those in suitable babies, we can do this procedure safely and predictably, even with a complex heart diseases. Okay. So that is a lesson from these two cases. Okay. So again, we'll break for questions if there are any questions. Okay, so no questions. We'll go to the next session. So next few sections are not challenging sections. Okay, they are all office practice sections. Okay, so all of you would relate to this cases very well. This is a 3-month-old baby admitted with us in Jupiter Hospital with respiratory distress. This happens to be a doctor's child. No murmurs, just respiratory distress. Okay, saturation normal. Okay, so X-ray shows cardiomegaly. So send for X-ray send for echo because X-ray shows cardiomegaly. What is the diagnosis? Diagnosis is TGA VSD with severe pulmonary hypertension. Okay. So again, going back to this patient. Okay. So there is tachycardia, there is gallop rhythm, and saturation is 84%. Okay. So whatever the saturation was measured in the when the patient is admitted is probably wrong because baby is very small and baby was moving. Okay. So this is an illustrative picture, not exactly the baby's picture. Okay. So saturation monitoring was completely missed in this baby for first 3 months, in spite of the parents being doctors. Okay. So the biggest myth in any cardiovascular examination is this. What is this? Auscultation. Okay. So what is this pediatrician doing? He's putting a stethoscope on the child's heart and he's listening for murmurs. What will he do? So if he gets a murmur, he will refer the patient to cardiologist. Okay. Cardiology is over for the pediatrician. Okay. If he does not get the murmur, then cardiology is anyway over because this baby does not get referred at all. Okay. So that means a pediatrician or a physician is just looking for murmur. Is it? So if this is the cardiology, this is actually not cardiology. This has to be murmurology. This is not what is desired by a clinical examination for cardiology. Okay. So this is a paper or this is a book written by Alexander Nadas in 1959. Okay. Long ago. Okay. Even at this point of time, these are the things that a clinician should look for to diagnose if the baby has a heart disease or not. This is widely available in all the textbooks and internet. Look for diastolic murmur, systolic murmur, cyanosis, CHF. Okay. So look for abnormal S2, look for abnormal ECG, X-ray, blood pressure. Then only conclude that the baby does not have a heart disease. Unless you do this, do not conclude that the baby does not have heart disease. So is it very old? Is it still relevant? Yes, it is still relevant. Okay. So this is a paper from JIPMER. Okay. So these people took it up as a PG thesis. Okay. This is in 2018. They proved that NADA's criteria is still relevant in present era. Okay. So basics will never die, even with ultra modern cardiologists, ultra-modern stethoscopes, ultra-modern echocardiography machines. What is available at bedside for a clinician is clinical acumen. Okay, so please do all the above. Then why is cyanosis missed? Why parents did not pick up cyanosis? There is a science behind this. There are many excuses, but not to miss. What are the common excuses? In the neonate, usually babies are not exposed. It's quite easy to miss cyanosis, okay, especially in cold environments. Lighting in the NICUs are often dull, okay, so especially if they do not have adequate ventilation, cyanosis will not be visible to the naked eye, especially in this NICU. Do you see there is no monitors in this NICU? Such NICUs are dangerous, okay. So familiarity and training, if a baby has so much cyanosis, anybody can pick up, okay. And in neonates, clubbing is absent, so cyanosis is easily missed. If a baby has saturation of less than 60%, easy to pick up. 60 to 80% only experienced hands can pick up. More than 85%, it is impossible to estimate saturation in any baby clinically. You have to use pulse oximeter. Okay. The second reason why cyanosis is not very apparent in neonate is because of high affinity of oxygen to the fetal hemoglobin. For apparent cyanosis to happen in a newborn baby, the desaturation has to be significant. Otherwise, babies will usually look more pinker than normal. Okay, so only solution is to put pulse oximeter. Okay, so this is a good Massimo or a Nelcor pulse oximeter, which you can invest and keep it in the clinics or in your ICUs. Okay, so check saturation at least once before discharging the baby from NICUs, or ask you train your nurses to do this. So this is a normal finger probe, a pulse oximeter probe. This is also accurate, but will require more time to do. Okay, so I think we are exceeding the time. Okay, so we can conclude here. So what does administrator say?
Yes, Dr. Srinivasan, we can wind up now because already it's 10:35.
Yeah, so we'll wind up this session here. Okay, so this would be the final message for my friends. Okay, so when you examine a child in your clinic, these are the vitals for your cardiovascular examination. What do you need? You need to take a very thorough history, do a comprehensive clinical examination. If possible, get an ECG done for reasons I told you. If ECG is not possible immediately, still that is okay. At least get a chest X-ray done if you suspect a heart disease. Definitely do a pulse oximetry and definitely check blood pressure as per the guidelines. Any child above 3 years should get a blood pressure checkup done. Any child above 5 years should get a blood pressure checkup done during every visit. So any child who's admitted in the ICU should definitely get a blood pressure checkup. So these are the guidelines for blood pressure measurement. Okay, so this will be the last slide for presentation today. Okay, if there is any time and any questions left, we can take them.
No questions, sir.
There are no questions. Bhavesh sir, your remarks?
There are many comments and many of them have liked the presentation.
Yes.
Before we conclude the session, just one practical question which not very often, but some of the pediatricians must have faced, that we often give a fitness for any prior surgery, the fitness for a general anesthesia, and everything is okay in the pre-surgery assessment clinically as well. And some of the patient, they'll end up in a complication because of the Takotsubo cardiomyopathy. Can we predict that in advance? And if not, how can we treat that? I mean, how to monitor it post? Because this typically happens after anesthesia. Any principle or guidance for the pediatricians?
Yeah. So for people who do not know what is Takotsubo cardiomyopathy is stress cardiomyopathy. Okay, so patients will develop severe ventricular dysfunction following any stress. Okay, so it is similar to bereavement cardiomyopathy. Okay, so it can happen with any surgical stress, anesthesia stress. Okay, so stress can be anything. Okay, so these patients can develop LV dysfunction. Okay, Bhavesh's particular question is, can we predict this? Usually you cannot predict a Takotsubo cardiomyopathy at all. Okay, so it can happen to anybody. Okay, even in adults, you cannot actually predict Takotsubo cardiomyopathy. There are no predictors at all. That means even if you have done an echocardiography and an ECG for these babies, you cannot actually predict a Takotsubo cardiomyopathy. One reason why babies develop LV dysfunction after general anesthesia, very common mistake that I've seen is when you conduct an anesthesia without monitoring CO2. Okay. Many of them do monitor continuous oxygen levels in your babies. Okay. Once you give general anesthesia, put the babies on oxygen, the oxygen saturation does not come down immediately, even with severe respiratory issues. Okay. Because the diffusion capacity of carbon dioxide is far superior to the oxygen. Usually hypercarbia is undiagnosed. Okay. Many such patients, if you have done an ABG immediately after the deterioration, you would see that the patient has severe respiratory acidosis and severe CO2 retention. Wherever it is possible, okay, so I would insist all the pediatric anesthesiologists to have some sort of an ETCO2 monitoring continuously intraoperatively. If you can do this, many of these surprises, many of these disasters after anesthesia can be avoided. Okay, so manage your fluids properly, monitor ETCO2, definitely monitor pulse oximetry. At least every 5 to 10 minutes once, you have to continuously monitor NIBP in all these babies who are undergoing general anesthesia. Okay, so absence of monitoring is the most common reason why these babies will have poor outcome after anesthesia unexpectedly. So this is not Takotsubo cardiomyopathy. What I'm saying is not Takotsubo cardiomyopathy. This is cardiomyopathy secondary to severe respiratory acidosis.
And I think there is one important and more relevant practical questions asked by Dr. Ram Sharma. And I think he has asked twice that please share any study which justifies that the oxygen is not needed at the time of a birth, resuscitation during the birth.
Okay, so that I'm not the expert about. We have a lot of big people who are running these NRPs. Okay, so Bhavesh is one of them. Okay, so I think
So if I
they
may
can share
answer
that
on your
presentation.
behalf. Yeah. So I mean, it's the NRPs come out with a very clear guideline that all full-term newborn baby, when need to undergo resuscitation, they should be started with the room air oxygen, which is 21% FiO2. Preterm baby more than 32 week also, if required, they need to do a resuscitation with the 30% FiO2. And in the initial step, in the first 60 to 90 seconds, if the baby does not respond to the initial resuscitation, then you need to think about the giving the oxygen, and that also in a titrating fashion. One most important point for all of us to understand and to practice also, that it is the ventilation, it is more important, and not the oxygenation at the time of a birth. When baby is not crying, it is the expansion of alveoli or ventilation which is more important than providing only oxygen. So I think that will answer the question of Dr. Ram. And as expected, excellent session, Dr. Srinivas.
Thank you, Mosh.
Bhavesh, that too on a cricket match day, more than 300 attendance.
Score क्या हुआ वैसे?
Already, I think Afghanistan must have lost 3 to 4 wickets. India 180.
Great. So our score is better than India's score today.
Yes. Triple century.
Great. So
Pushkar,
thank you very
you
much.
can
I think
conclude.
concluding remarks.
Thank you, IIP. Thank you, President Dr. Ram Gopal Chezara sir, and thank you, Secretary, our Secretary Dr. Amol Paur sir. Also, thanks to Dr. Bhavesh Mithya sir for coordinating with all the legions and taking all the efforts for this series. Thanks to Dr. Srinivas sir for such an excellent presentation. Thank you, sir.
Thank you,
all
friends. Thank
the
you very much.
delegates also.
Thanks for the opportunity.
Yeah.
Thank you.
See, today we have learned something different angle of cardiology, all the procedures. So I think it was a quite different session. What we learn in our conferences. Thank you, Dr. Srinivas.
Right.
Thank you very much.
Yeah.
Thank you, sir. Thank you, Bhavesh sir. Thank you, Srinivas sir. Chalo.
Good night, everyone.
Thanks, Suman.
Good
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 night.
night.
Yeah.
Madam, recording stop करा पल्ले ना.